This is a great misconception for two key reasons. The first is these RCTs often relate to very narrow cohorts.
The value trial is certainly an important study, but even important studies may present some issues and limitations.
First of all these studies are talking about pure or uncomplicated or index patients with stress urinary incontinence, and unfortunately the definition is not clear.
So when is something uncomplicated? When there is stress urinary incontinence for more than 3 months without much residual urine, so residual urine of less than 150 mils after voiding, and when it's clearly seen in physical examination. So when you examine the patient and there is urethral hypermobility and evident stress urinary incontinence, then it's uncomplicated.
How many patients we see are really uncomplicated? If we look to the value trial, we could say around 1/3, 34% of the patients screened were really uncomplicated. And almost the same results came from a study we did in Italy, where 36% of patients were considered uncomplicated. And almost the same results also came from a very recent study published from an Argentinian group, where around 40% of patients were considered uncomplicated. All these studies were using the criteria of the value trial. If you use stricter criteria, as done in the past in 2 British studies, this number could be even lower, around 10 or 5%, as shown in papers by Di Gesu and Agor.
Let me reiterate. The patients in this trial were patients with uncomplicated symptoms of stress incontinence. And in my practice, this is a relatively rare clinical situation.
Since population, specifically in the industrialized countries, are rather getting older, and with age, other health problems increase, including lower tract symptoms and dysfunctions, those so-called uncomplicated or easy patients are becoming rather a smaller group.
The other limitation is about the primary endpoint, that was treatment success at 12 months. And I think that probably a diagnostic test should be evaluated more on the ability to guide the following treatment choice, more than to evaluate the outcomes of a surgical treatment.
They are, in effect, attempting to assess the quality or the accuracy of a diagnostic test using the success of a treatment. And you can see this is, of course, conceptually problematic.
For example, in the value study, without doing preoperative urodynamics, you would miss detusor overactivity or detusor underactivity in a total of 56% of patients. In other words, the clinical diagnosis in that study was altered by preoperative urodynamic studies in 56% of patients. But interestingly and surprisingly, this was not reflected in the outcome of surgery at 12 months. On the other hand, we know from the literature that both detusor overactivity and underactivity are poor prognostic factors for the outcome of stress urinary incontinence surgery. But unfortunately, the details of urodynamic studies were not given, and it was also not reported how the change of clinical diagnosis affected the preoperative patient counseling by the physician. And we do not know the outcome of detusor overactivity and detusor underactivity in that patient group in the long term. So in my understanding of good medicine, I would not skip a test which will change my clinical diagnosis in more than half of my patients.
Another limitation is about the decision making. It's difficult that a test, a preoperative test, can change the outcome if at the end the surgeon will perform every time the same surgical approach. It's illogical to suppose that a pre-op test could change anything in the following process if at the end the strategy is not modified by the results we have from a test.
When evaluating these studies, you have to be crystal clear about the technical side of how the study was conducted. And one of the key things is to make sure that the population sample is big enough to be able to detect small differences between populations. And then, of course, one of the key aspects that we are dealing with clinically is that these tests are about measuring the situation for an individual, not a population.
And often patients who sit in front of us are not interested in general success rates. They want the individual, what's going to happen to me question. And that can truly be only answered with urodynamics.
And so you get a substantial difference at an individual level. Specifically, you will understand properly that person's mechanism of symptoms. And not only that, you will get additional information about potential risk factors for bad outcome.
Hence, these studies actually do not show and cannot be simplified to the conclusion, do not do urodynamics at all. Rather, or in contrary, they show or highlight that each physician has to carefully consider who is actually treating with which problem and if he or she has all the information and proper indication to proceed with the therapy in mind. If not, urodynamics are a valuable tool to provide more detailed information that helps to confirm or reject the initial treatment decision.
So in summary, the published evidence needs to be reviewed with considerable care. And furthermore, the clinical context of treating an individual is a rather different one from the published evidence research basis.
There is a wealth of observational studies which demonstrate the clinical utility of urodynamics, both in terms of directly guiding and directing management, as well as giving us probabilities of success on an individualized patient basis. So we should not disregard these prospective observational wealth of evidence just because some RCTs have demonstrated that in very narrow bandwidth of patients that urodynamics may not make a difference in the outcome.
However, this debate also shows that there is the need for clarification how we should best utilize urodynamics investigation in our daily clinical practice.